Hello everyone, my name is Amir. I'm the Hematology Registrar. Welcome back in the Hematology Bleeps. Let's discuss about something new in these Bleeps, which we usually receive mostly from the emergency department, that is post thrombolysis bleeding, especially intracranial hemorrhage after the thrombolytic therapy for the ischemic stroke patient. So post-thrombolysis, intracranial hemorrhage or other sort of bleeding is a common complication of the thrombolytics or fibrinolytic therapy, and the ED team usually get panic what to do with that, and they start calling the hematology team that our patient is bleeding now. What intervention should we do urgently in this patient? Every trust in the UK has some guidelines about that, but if you don't, there is a British Society of Hematology guidelines about post thrombolysis bleeding in the patient. Different trust use or different hospital across the world use different type of thrombolytics for the clot lysis or for the ischemic stroke or for massive pulmonary embolism. It can be alteplase, streptokinase, it can be urokinase, and there are many others as well. Their half-life is small, but like in minutes, and only one of them has a half-life up to an hour or 80 minutes, and this is streptokinase, which has a long half-life. The others one, they have less than half an hour on average for their action. Very very small half-life, but the problem is that their anticoagulant or antithrombotic effect remains for some time, for a day at least. That's why these patient needs monitoring after the thrombolytic therapy to see if the patient develop any bleed or not. They may develop bleeding during the infusion. They may develop bleeding within 24 hours of infusion. That's why we do. That's why the medical team or the emergency team or stroke team, they do regular frequent ops for the neuro ops for their patient to exclude complication of intracranial hemorrhage. So if a patient develop bleeding after the thrombolytic therapy, after using alteplase, streptokinase, or urokinase, why these patients develop bleeding? Because the thrombolytic therapy eats all the fibrinogen in the patient. So due to decreased fibrinogen, these patients are at risk of bleeding. Fibrinogen is an important component of the coagulation pathway. When fibrinogen disappear from the blood, um, the plugs, platelet plugs, they cannot form, they cannot stop bleeding, so patient has high potential to bleed. Secondly, they block the factor 5, important coagulation factor, which is factor 5. It is blocked, and the environment in the body with the disappearance of coagulation factor 5 and fibrinogen becomes bleedy. The anticoagulant environment develop in the body, and patient is at risk of bleeding. The another problem is that these thrombolytics, they lyse the they lyse the clots, and during this clot lysis, they eat away or lyse the fibrinogen um, and the and prevent platelets from its effect, and prevent and block the factor 5 as well. So the three main pathogenic factor in thrombolysis induced bleeding is decreased fibrinogen, antiplatelet activity, and the uh, coagulation defect, which is in factor 5. This lead to bleeding in the patient. There is a specific performer before the thrombolytic therapy, which the medical team or the emergency team would know better than me. They check all these. They tick all the boxes when they are planning thrombolytic therapy for their patient. So who are at risk of thrombolytic related bleed and who are not, the medical team and emergency team would know better than me. So once the bleeding happen, we need to reverse this bleeding. As we mentioned, thrombolytic drugs, they eat away fibrinogen, so we have to replace the fibrinogen in a patient. So we have to give this patient cryoprecipitate. Or if your hospital has fibrinogen concentrate, you can use fibrinogen concentrate as well. The patient, the thrombolytic drugs have antiplatelet activity, so you need to give this patient platelets as well, platelet transfusion. And make sure the infusion is stopped and you have stopped all the other antithrombotic drugs in the patient. So give this patient fibrinogen concentrate or cryoprecipitate, give this patient platelet transfusion, give him vitamin K, vitamin K as well. And because the coagulation factors are affected, as we say, they block factor 5, better to give this patient FFP as well. The dose is 12 ml per kg as per the BSH guideline, British Society of Haematology guideline. So this is initial bit, the emergency treatment for the thrombolytic related bleeding in the patient, which is fibrinogen concentrate or cryoprecipitate, then the FFP 12 ml per kg, third the platelets transfusion, fourth tranexamic acid, IV or oral, and vitamin K. Check the fibrinogen, close fibrinogen in the patient after um, 30 to 60 minutes, okay, to see if you need further fibrinogen in the patient or not. Because the thermolytic activity of the drugs, altiplase, retiplase, or urokinase or septokinase, they remain in the body for some time. It is better to check the coagulation screen and cross fibrinogen after 30 minutes, and then at 12 hour, and then 24 hour. The gross fibrinogen in the body will come back to its normal level, usual level, within 48 hours, usually 48 hours, um, because the thermolytic activity can remain in the body for long as well. That's why we have to check the coagulation screen and gross fibrinogen initially after 30 minutes of cryoprecipitate of Hepclot infusion, and then at 12 hours, and then at 24 hours. Okay. And the usual common question from the emergency team or the stroke team is that, well, this patient had a big ischemic stroke. That's why we give this patient thrombolytic therapy. Now this patient has intracranial bleed. Should we give antiplatelets or not? No. If there is any intracranial hemorrhage post thrombolysis and the patient background was stroke, you will not give this patient aspirin. If you give this patient aspirin or clopidogrel, the hematoma, the intracranial hemorrhage, it will get worse. Okay, there will be new bleeds or the current bleed will expand. So wait for at least 2 hours. Wait for at least 2 weeks and repeat the imaging to make sure the hemorrhage is stabilized, no further extension, patient is clinically stable. Then you can introduce antiplatelets after 2 weeks of time. But if the ischemic stroke was massive or the intracranial hemorrhage was massive, then it becomes case by case discussion. But withhold antiplatelets for at least 2 weeks after intracranial hemorrhage. So this was a short talk about bleeding after thrombolysis treatment. We do receive these calls once in a week time in our trust that patient has thrombolytic drugs exposure, and now the patient has bleeding. Thrombolytic drugs can be taken for many indications. It can be for thrombolysis in ischemic stroke, thrombolysis in the pulmonary embolism, um, sometime the line blockage if heparin is not working, and many other indications as well. But we do receive a lot of calls regarding the uh, thrombolysis related intracranial hemorrhage especially, or bleeding. So give them cryoprecipitate or fibclot, give them FFP, give them platelet, give them vitamin K, give them tranexamic acid, make sure you have stopped the antiplatelet or sorry the antithrombotic or thrombolytic medications in the patient. So thank you very much. But if you still have any question, you can write it in the comment, or if not, then you can bleep your hematology team. Thank you.